Good morning, everyone. Welcome to Pedia Academy by Dr. Pankaj. Myself, Dr. Pankaj, and we are discussing this amazing series on NEET SS previous year's topics. So today we are discussing the important topic of
Okay, we will discuss autosomal recessive polycystic kidney disease ARPKD. This is very important disease. This is also called as ARPKD congenital hepatic fibrosis because in this disease what are the main common organs are involved are kidneys and liver. Just remember this is autosomal recessive. Kidney is obviously involved and liver involved as congenital hepatic fibrosis. This is very much important. Next important thing in this, what is the gene? Gene is PKHD1 gene. Okay, it encodes fibrocystin and over 300 pathological variants are seen. So just remember this is autosomal recessive polycystic kidney disease with congenital hepatic fibrosis means kidneys and liver are two organs which are involved. Mutation in gene is PKSD1 gene and it encodes fibrocystin, a large protein more than 4,000 amino acids. If we talk about pathology of this condition, kidneys are markedly enlarged. Just remember this. In autosomal recessive polycystic kidney disease, kidneys are markedly enlarged with numerous small cysts in cortex and medulla leading to corticomedullary differentiation is lost. So this is very much important. Dilated and ectatic collecting ducts and progressive interstitial fibrosis leading to end-stage renal disease. So kidneys are enlarged with loss of corticomedullary differentiation, small cyst in kidneys. Okay, now we'll talk about liver. So liver hallmark of this condition is congenital hepatic fibrosis. What occur in this? Bile duct proliferation and ectasia, progressive hepatic fibrosis due to ductal plate abnormalities. Okay, so how this disease develops? Basically, fibrocystin, which is the gene product of PKSD1, it interacts with other cystic disease protein influencing intracellular signaling. Some environmental and genetic factor also involved, but they are not that known. Okay. So which type of mutation leads to which type of disease? If it is missense mutation, milder disease will be there. If it is truncating mutation, severe disease will be there. Just remember, although genetic diagnosis is 90% accurate, but in 10% of cases, false negative diagnosis are seen. Okay, so what are the clinical manifestation in neonate, a newborn baby presenting with bilateral flank mask. Okay, just see from antenatal findings, oligohydramnios and bilateral enlarged kidney. You are seeing a USG report of a mother and you are seeing oligohydramnios and bilateral enlarged kidney. Just keep in mind of autosomal recessive polycystic kidney disease. When newborn is born, what are the neonatal symptoms? Bilateral flank mask, respiratory distress leading to spontaneous pneumothorax. This is very much important. And oligohydramnios complex, that is Porter syndrome, is seen. So basically, oligohydramnios and other things like spontaneous pneumothorax, oligohydramnios complex Porter syndrome is seen. Is there any peculiar facies? Yes, Porter facies you can call them. Low set ear, micrognathia, flattened nose, and limb positioning defect. All are the part of this Porter syndrome spectrum. Pulmonary hypoplasia. Yes, this may occur, and if it occur, then it is high mortality more than 30%. Severe hypertension is the hallmark within first few weeks. Requires multi-drug therapy. Just remember, transient hyponatremia is also featured. So, which electrolyte abnormality is seen in autosomal recessive polycystic kidney disease? It is transient hyponatremia. Kidney functions are normal in 20 to 30% of the patients, but 50% of patients of end-stage kidney disease develop the kidney function deterioration. If this is not presentation of neonatal, some patients presents late onset, infant or young adult presentation is also seen. In this condition, it may be mixed renal hepatic disease which presents in infancy, childhood, even adolescence. In later age, liver involvement dominates in many older children. Okay, so if it presents later, then liver manifestations are more important. In liver manifestation, portal hypertension, hepatosplenomegaly, GE varices, ascites, and other thing recurrent ascending cholangitis. So liver involvement is more severe. Kidney finding may vary, but liver is definitely more severely involved in late onset or young adult presentation. Okay, so just see this image. This is actually 3-month-old infant having massive abdomen enlarged, and you just see enlarged kidney. How you will see, you do x-ray, and on x-ray only just see how they are enlarged. Two kidneys are almost filling up whole abdomen space. When we do USG of this, you are able to see small cyst and loss of corticomedullary differentiation. Again, the presenting feature we are coming to massive prenomegaly. This is massive, and on USG, small cyst with loss of corticomedullary differentiation. This is hallmark of autosomal recessive polycystic kidney disease. Phenotypic classification, as we know, it 40% severe kidney and severe liver disease, and other like combination of these. So the severe disease are more common. How you will diagnose this autosomal recessive polycystic kidney disease? This is mostly clinical and ultrasonographic diagnosis. How you will suspect this? If a unit presents bilateral flank mass, pulmonary hypoplasia, hypertension, and absence of parental renal cyst on ultrasound. Why this is important? Because presence of paternal renal cyst on ultrasound shows autosomal dominant polycystic kidney disease. Okay, suggestive of. So this parental renal cyst should be absent for diagnosis of ARPKD. USG finding, as we discussed just now, enlarged hyperechogenic kidneys with poor corticomedullary differentiation. In liver disease, if we happen to do liver biopsy, ductal plate abnormalities are seen. So ductal plate abnormality, just for revise, paucity of bile duct seen in Alagille syndrome, and ductal plate abnormalities are seen autosomal recessive polycystic kidney disease. Genetic testing, as we discussed earlier also, these are 90% sensitive. Are there any differential diagnosis? Yes. Multicystic dysplasia, hydronephrosis, Wilms tumor, bilateral renal vein thrombosis are the differential diagnosis, and nephrophthisis also can be seen. Are there any prenatal testing available? Yes. Genetic linkage analysis and direct pathogenic variant testing is available. Okay. So, pre-implantation genetic testing for in vitro fertilization is available. So, what is the treatment of autosomal recessive polycystic kidney disease? It is mostly supportive, aggressive ventilatory support, hypertension management. Kidney management, you have to do diuretics of fluid overload. What are the indication of nephrectomy? If kidney size impairs respiration or feeding, renal replacement therapy can be done. Liver management, like portal hypertension, recurrent cholangitis, and severe hepatic fibrosis. For severe hepatic fibrosis, you have to do liver transplantation. Other disease, you have to do variceal bending, antibiotic, and bile acid therapy. Combined liver kidney transplantation is considered for the patient both end-stage kidney and liver disease. So what is the prognosis? Neonatal mortality is around 30% in ARPKD due to the reason is not kidney. The reason is due to pulmonary hypoplasia. Survival improvement, more than 80% 10-year survival for those surviving infancy, and 70 to 80% in 15 years survival rate. So the initial period is very much important. So what are the major complications like chronic kidney disease, portal hypertension, ascites, and cholangitis? So this was about autosomal recessive polyconium ileus. We'll discuss some another topic of this amazing series. Till then, do share, like, and